in the next couple of minutes, I will go through some, these are my disclosures, some of, let's say, not any more COVID-19. So we have lots of COVID-19 in 2022, and I think in 2023 we have lots of papers on infection, but with other topics. And I struggle a little bit to find which one I would like to present to you and to give you a short snapshots. And I decided to go through a couple of epidemiological studies, management of infection, of antibiotic dosing, one RCT, and some additional papers. And I will give you quick snapshots. So the Eurobact study, has been published this year, is the largest study on hospital-acquired bloodstream infection in ICU patients. So it's 2,600 patients. And what is striking is that almost 60% was caused by gram-negative with a high frequency of carbapenem-resistant and difficult-to-treat resistant pathogens, so almost 1/4. And antimicrobial therapy was only appropriate in the first 24 hours for half of the patients, with an impact on mortality. And the overall mortality was quite high at 28 days. So the clinical implications of this is that we have to work on prevention of resistance, but we need also to improve the way we prescribe antibiotics to increase the appropriateness of antibiotic therapy and also to improve outcome. The other also important epidemiologic study is the EUREKA. EUREKA is also the largest study on meningoencephalitis in ICU patients, almost 600 patients. And at 3 months, half of the patients had poor functional outcomes. More or less half died or half as a moderate to severe functional disability. And the risk factors for these were patient characteristics, but also time to ICU admission, neurologic presentation, antimicrobial therapy, respiratory and cardiovascular complications at admission. And this study is going on to assess the 1-year outcome of survivors. And so the clinical implications is the need a better process of care. So we have to admit earlier these patients in our ICUs and also prescribe earlier antibiotics. The next epidemiologic study that is quite interesting is the SIM-DRA. The authors tried to assess the relationship between immunosuppression and intensive ICU-acquired colonization and infection related to MDR pathogens. They included 750 patients, of which 264 were immunocompromised, and the immunocompromised patients had significantly lower incidence of ICU MDR colonization and a similar ICU MDR infection, and no significant association between ICU MDR colonization and or MDR infection and 28-day mortality, ICU Lancashire, and invasive mechanical ventilation. And so the probable clinical implication is probably these patients, there is no need for a different empiric antibiotic therapy when we admit them, and the authors are doing a larger study to confirm these findings. And the last one is the ANIRI study, the European Network of ICU-related respiratory infections. This study included more than 1,000 patients with lower respiratory tract infection, and they divided in different types of infection: ventilator-associated tracheobronchitis, ventilator-associated pneumonia, and then hospital-acquired pneumonia that needed to go to the ICU. Of those that came from the ward but needed ventilation, and ICU hospital-acquired pneumonia, with different numbers. But what was striking was that VAP and VAT had the same mortality, and the one with higher mortality was the ventilated HAP. The most common pathogens were Pseudomonas and Klebsiella, with more MDR in VAP and the ventilated HAP. And so the clinical implications here is why these patients that are in the ward develop VAP came to the ICU, need to be ventilated. They have such a higher mortality, probably a late referral. And another thing is that was unexpected because previous studies show that VAT has a lower mortality in comparison with VAP. Probably people are using the term interchangeably. So concerning the management of infection, I think you should read these guidelines because they are the first guidelines on CVCAP. And we all know that CVCAP has a high mortality and morbidity. And in these guidelines, so the authors presume that all patients have been started on a beta-lactam, and then they issued 8 recommendations on diagnosis, antibiotics, organ support, biomarkers, and coadjuvant therapy. So they have to be commended to written the first CVCAP guidelines, and also that could improve the process of care in different settings, and also they identify a couple of unmet needs. The other paper related to the management of infection is a sub-study of the abscess observational study of secondary peritonitis. More than 1,000 patients included with documented secondary peritonitis. Mortality was almost 30%. And they compared the timing of source control. That's always an issue. And what they saw is the emergency source control with less than 2 hours compared to urgent, 2 to 6 hours, was associated with a lower mortality and also as well as a successful source control. And that was a surprise. The appropriate empirical antibiotic therapy did not reduce mortality, was not associated to a lower mortality. So in secondary peritonitis, a moderate postponement of the intervention as well as successful source control had a significant impact. And finally, this is more related to research, but is an interesting paper looking at the different signatures of the gene expression in patients with influenza-associated pulmonary aspergillosis. Small number of patients, but they studied the differentially expressed genes in BAL, and comparing survivors to non-survivors, they saw that those that were non-survivors as a downregulated of expression of some of these genes related to antifungal immunity, and some of them related to recognition of aspergillus. And concerning 23 significantly upregulated genes, several were linked to vascular endothelial growth factor, and so that could be data is implicated in ARDS. And so this could be translated in future to future therapeutic targets. Concerning antibiotic dosing, this is always a matter of discussion in every place. This randomized controlled trial, the Dolphin trial, assessed a modeling for precision dosing to improve antibiotic dosing of beta-lactams and ciprofloxacin. And again, there was no beneficial effect in the target attainment at D1 and D3, as well as ICU length of stay of critically ill patients. So the clinical implication is that we need for new approaches to dose optimization and need to improve these platforms. And another study assessing the different models of dosing of piperacillin, that was also a systematic review. So the study investigated external validity at 24 models for piperacillin in a multi-center cohort of 561 patients from 11 centers and 3,654 concentrations, and the predictive performance of these models was varied a lot, highlighting the relevance of appropriate model selection and improvement also. So these models are not yet ready to be used as clinical decision support systems, so there is room for improvement. Concerning the RCTU, the PrevUp trial was a trial to assess the role of interferon gamma-1 beta in the prevention of HAP via immunostimulation. So more or less 55 patients in both arms. It was stopped for for safety, in the secondary interim analysis for safety problems, because there was a higher rate of HAP, but the mortality was similar. So we need a better understanding and a better understanding of the immune response, and also a better selection. Maybe some patients could benefit of these, others don't. And I would recommend some additional reading. One is a narrative review trying to differentiate infection, colonization, and sterile inflammation in critically ill patients. It is quite interesting. And two others papers, one on fever, that is also always a matter of discussion of what to do and what does it mean, and also a target immunomodulation, a primer for intensivists. And I would like to finalize thanking the office, the editorial team, and the editor-in-chief, and that also very proud for the old authors that participated in these papers, and a special thanks for the reviewers that help us to improve a lot all these papers. Thank you.
Thank you very much, Pedro, for highlighting the key papers and for stimulating us to go back and read them at home. Are there any questions from the audience? Yes, please. Oh, sorry. I thought I misinterpreted the...
Pedro, I have a question. You talked about about the guidelines on community-acquired pneumonia. Are there specificities for immunosuppressed patients?
No, they are not. If these guidelines are not for immunosuppressed patients, are for let's say immunocompetent patient, for what that could mean, but it's not for that.
Thank you.
There's a question here.
Olaf Kremer from Utrecht. Yeah, so you mentioned the abscess study, and you seem to suggest that there could be a causal link, that delayed source control for 2 to 6 hours would be associated with better outcomes. I think we should be really careful there, because of course there's a lot of confounding here. But the question is what is defined as T0? Because of course T0 is the time at which the problem is basically being identified. It's not the time that the abdominal leak, for instance, started, of course. So could that not be confounding there?
That's a good point, but again, unfortunately, in infection, the time zero, it's almost impossible to know. In pneumonia, in peritonitis, maybe peritonitis is a little bit better because there is a pain associated, but you are right. The time zero is when someone identified the problem, that with all the limitations.
Pedro, could I ask you one question? So what's the key advance in the last 12 months related to infection?
Among all these papers?
Yeah, in all the papers, yeah.
For me, I think this one of the postponing a little bit, the not rushing immediately to the theater, because there are other papers showing that until 6 hours, the outcome is not that bad concerning source control. And the French study by Saad and Sir, I think, is quite interesting in terms of the one of immunocompromised patients that have a lower rate of ICU-acquired MDR colonization and ICU-acquired MDR infection. That could be related just to our practice, because we isolated those patients. We have more care with them comparing to the others. If it is confirmed in further studies, I think could lead to a different prescription when they have a suspicion of infection.
Thank you very much.